Hi, welcome back. We're still here. We're doing the CCFP 105 topics.
Today's topic is shortness of breath, and today's episode is short and sweet.
It was written by that voice you just heard, Vaishvi Patel. Her second episode. She's a third-year medical student from the University of Alberta, and this time she got an assist by Ronan Noble, an MD PhD student from the UofA.
Yeah, and it was reviewed by Dr. Whitney Hung, an internal medicine senior resident in Edmonton, Alberta.
Thank you so much, Dr. Hung. Vaishvi, of course, has joined us today. We're talking about shortness of breath.
Thank you so much for having me on.
Cool, let's do it. Should we do it?
Yes.
Objective 1. In a patient with a new presentation of shortness of breath, takes sufficient history to avoid inappropriately or prematurely limiting the diagnosis to just respiratory and cardiac causes.
Now, this is extremely important to keep in mind because for many of us, our brains immediately jump to cardiorespiratory causes. The most important thing is to always obtain a thorough history in which you can utilize the OPQRST mnemonic to get an understanding of the timing and presentation and to ask about associated symptoms.
While you're taking that history, or if you've already done it, brainstorm a few potential causes for their shortness of breath. Try and keep it broad. You can use your mnemonics, whatever you learned before, whatever you're comfortable with. Vitamin D, Vindicate, Dimes, etc., etc.
Aside from run-of-the-mill bacterial and viral cardiorespiratory causes, some other ones would include
foreign body aspiration,
epiglottitis and
abscesses,
neuromuscular diseases such as myasthenia gravis and ALS,
GI issues like abdo-bloating from IBS, celiac, ileus, bowel obstruction, etc., because of the abdominal pressure causing you difficulty breathing.
There's also hematological causes such as hemorrhage,
anemia,
and carbon monoxide poisoning.
It's a favorite to test about. Psychogenic or supratentorial causes are often diagnoses of exclusion, but they might look like things like
anxiety disorder,
panic attack or panic disorder,
and hyperventilation.
And finally, even patients experiencing pain can have a sense of shortness of breath.
Perfect. We've included a great little table from EB Medicine that breaks down the differential diagnosis for dyspnea, and you can find that in the show notes.
Yeah, it's pretty good. To wrap up this whole section, it's important to have a broad differential, have something in mind, have a structure, because you're never going to remember all those things unless you're super brain. But there's another aspect that's arguably even more important to consider.
And that brings us to our second objective.
Objective 2. Regardless of where you assess the patient who presents with shortness of breath, consider life-threatening conditions.
There's many of these conditions, and they all present with shortness of breath along with some other symptoms. And this can include conditions such as, but are not limited to,
pneumothorax. This is usually caused by blunt or penetrating chest injury, medical procedures, or damage from underlying lung disease, or it might happen for no obvious reason, specifically in tall, young males. Look for shortness of breath, tachypnea, tachycardia, hypoxia, cough. On exam, you might find cyanosis, unequal breath sounds, hyperresonance on one side, tracheal deviation away from attention.
Pulmonary embolisms. Patients often have risk factors such as cancer, history of heart disease, clotting disorders, or recent travel or OCP use. These individuals have a similar presentation to pneumothorax along with pleuritic chest pain, pre-syncope or syncope, S3 or S4 heart sounds, or limb edema suggestive of a DVT.
Yeah, know your Perk and Wells rules. Myocardial infarct is next. Usually it's going to be in older folks. They're going to have some of those cardiovascular risk factors that you know about. It usually presents with chest pain that's going to feel more like pressure. Something sitting on your chest is the classic. Tightness, pain, squeezing, or aching. It could radiate to the shoulders, the jaws, the teeth, even into the abdomen, especially in older women and people with diabetes. Be very careful because they'll present weirdly. And along with this, they might have some nausea. They might be pre-syncopal, diaphoretic, and then on exam, you're looking for things like, again, cyanosis, edema, particularly to the lower limbs, pallor, diminished pulses, delayed cap refill might suggest vasoconstriction, diminished cardiac output, and RV dysfunction or failure.
Now for epiglottitis, patients usually have a severe sore throat, hoarse voice, They're drooling, there's some dysphagia or adenophagia, which may improve when they're leaning forwards. You may also notice a stridor or cyanosis, and this patient may also be febrile due to the underlying infection.
Classically, this is that tripoding and sticking their chin out like they're in sniffing position, like they want to be intubated, because they do. For foreign body aspiration, you might not be able to get a good history depending on the age of the patient, because usually these are going to be little kiddos. And the presentation might be coughing, wheezing, dyspnea. They might have hemoptysis or choking. They might have none of that, but mom or dad will tell you that they had a little bit of that and something's missing from the dresser or something like that.
And finally, we've got anaphylaxis. This usually develops suddenly and gets worse very quickly. These people usually have a history of an interaction with a trigger, such as an allergen. Signs and symptoms would include presyncope, shortness of breath, tachypnea, tachycardia, a wheeze, clammy hands, or allergy symptoms such as pruritus or hives or angioedema.
Big list of stuff, and for many of these, your patient's likely to have acute dyspnea associated with them, and they might have worsening status and vitals, but not always.
It can be very easy to overlook these conditions, especially when patients present with minimal symptoms. So it's crucial to always have these on your differential and to rule them out. If you do suspect any of these, urge or facilitate transport of your patient to the nearest emergency department.
Yes, we will take them. We've covered what you should do for a patient with shortness of breath, but there's a little more to the story yet. Objective 3. When a patient with a diagnosed cause of dyspnea presents with worsening symptoms or treatment failure, ask them about factors that might have exacerbated their symptoms, reevaluate your primary diagnosis, and consider coexisting diagnoses.
All right, well, this objective is pretty self-explanatory, so we can probably move on to the next.
That was so easy.
But jokes aside, this objective highlights yet another important aspect of management of patients with dyspnea. So if a patient's condition worsens after receiving treatment for their symptoms, there's definitely more going on than meets the eye.
If this is happening to you, circle all the way back, start over, get more questions in, get a more detailed history, spend time. Your patient deserves it. So consider asking about things like
treatment adherence or technique,
association with physical exertion,
any environmental changes,
any recent travel, you're thinking a clot in the leg and the lungs,
new pets,
dietary changes,
or drastic changes in lifestyle or recent illnesses.
And then certain thoughts or life events. You're kind of looking into that supratentorial end of things.
Most of these can contribute to exacerbation of symptoms of COPD and asthma, physical exertion for congestive heart failure, dietary changes for potential anaphylaxis with the exposure to an allergen, and thoughts and negative life events leading to any sort of symptoms of anxiety.
Along with all this, there's some signs and symptoms that can help you tie your story together, like chest pain, pedal edema, shortness of breath, etc.
Now, if you've asked further questions and nothing sticks out, you could start considering a coexisting diagnosis. For example, a bacterial pneumonia infection on top of asthma or COPD with pulmonary hypertension, or congestive heart failure with COPD, or even asthma with COPD.
The bane of our existence. Many diseases can present the same way, especially if they're in the same body system. So redoing a thorough physical exam, running general labs or imaging might help confirm your primary diagnosis, or it could shed light on a new one. So the recommendations here are get a CBC, looking for anemia and infections, etc. Renal function, liver enzymes, and liver function tests. Thanks for breaking those up. That is one of my rants. BNP, if you're going down that track, is a consideration. Troponins and ECG if you're thinking a cardiac cause. Electrolytes, lipids if you're in the more of the long-term risk factors. CRP, thyroid function, PFTs or spirometry, chest x-ray, and consider an echocardiogram. There's a lot of stuff you could do.
And then the CFP has recently published an article, which we've listed again in the show notes, about distinguished asthma and COPD, and essentially differentiating the two, and the management will be based sort of on the medical and family history, signs and symptoms, as well as the spirometry results.
And if you can believe it, that ties us into our last objective. Objective 4. In an anxious patient with shortness of breath, don't assume anxiety as the cause of their symptoms.
This objective loops back to the first one we covered today, once again highlighting the importance of having a broad differential and not making assumptions.
Yes, so a patient with anxiety or an anxious patient presenting with dyspnea, keep in mind the symptom could be due to those same cardiac, pulmonary, GI, neurological, environmental causes. You still need to consider those life-threatening conditions because if you can't breathe, you're going to feel anxious.
For anxiety, you first want to start off with a history, a mini mental status exam. Ask the patient to fill out an anxiety questionnaire such as G87 or PHQ-9, and then follow that up with a complete physical exam.
And it's a good idea to get some testing to rule out other causes that we mentioned, of course. If those come back negative and the patient does have signs and symptoms meeting the DSM-5 criteria for generalized anxiety disorder or panic episodes disorders, then that's where you're going to be able to track, but you can reassure yourself that you've ruled out all the other medical stuff.
Yeah, it's important to take these measures to ensure that you haven't missed anything and to provide your patients with proper management.
I think that brings us to the end. That's it.
I think so too, yeah.
Oh my goodness gracious. I love these 4 objective ones.
Quick podcast for sure.
But it's helpful, it's useful, lots of pearls in there. Thank you again to Vaishvi and to Ronan for writing this episode, and thank you so much to Dr. Hung for reviewing it and to Vaishvi for getting Dr. Hung on board.
Yeah, thank you all listeners for tuning in, and if you have any further questions or feedback, please feel free to contact us.
Bye-bye.
Bye for now.